Assalamu alaikum. Today our lecture is about multiple sclerosis, which is a demyelinating disease of the central nervous system. The inflammatory demyelinating disease of the central nervous system is classified into different types. The first one and the main type is multiple sclerosis. The second is acute disseminating encephalomyelitis, which we call it Adam disease. The third is neuromyelitis optica, Divic disease, which we discussed in the previous lecture. And the fourth one is acute and subacute necrotizing hemorrhagic encephalitis. Multiple sclerosis, which also known as MS, was given its name because the demyelination affects numerous sites of the central nervous system, and the sclerosis mean scars. The historical view of MS back to the 14th century, but the history really beginning at the 19th century, with the first clinical description of the disease beginning to appear in 1838 and first clinical case diagnosed in 1849. In 1868, the Charcot gave us the first sign and symptom of multiple sclerosis. MS is an autoimmune disease in which abnormal immune system directed against the central nervous system and attacks the myelin sheath, which is the fatty substance surrounds and insulates the nerve fiber, as well as it may attack the nerve fiber themselves. So, when the myelin sheath and the nerve fiber is damaged, the nerve impulses traveling to and from the brain and spinal cord are interrupted, producing a wide variety of symptoms. MS is the most frequent demyelinating disease, with a prevalence that varies from high level in North America and Europe to low rate in Eastern Asia and Sub-Saharan Africa. Approximately about 2,500,000 of people in the world have multiple sclerosis. 70% of the patients manifest symptoms between the age of 21 to 40. Like other autoimmune disease, MS affects female more than male. What about the causes of MS? There are many factors in relation to cause of multiple sclerosis, and the main one is immunological causes. Also, it may be due to infection with certain viruses and bacteria, and these include measles virus, a human herpes virus type 6, Epstein-Barr virus. Also, environmental factors such as lack of sunlight and vitamin D deficiency also involved in the cause of MS because it's more common in countries far away from equator. A smoker person are twice as likely to develop MS. Also, exposure to certain toxic substances may cause MS, like heavy metals or solvent. In 2013, a study suggested that too much dietary salt may trigger the autoimmune reaction and lead to causes of multiple sclerosis. The discovery of family aggregation in the second half of 19th century shed the light for the first time on the genetic component of the disease. Compared to lifetime risk, of 0.2% in general population, sibling of affected individual have a 10 to 20-fold higher risk of disease, with monozygotic twins having a 30% higher risk of the disease. The whole pathology in patients with multiple sclerosis is the cerebral or spinal plaque, which consists of a discrete region of demyelination with relatively preservation of axons. Atrophy and ventricular dilatation is also seen. Disruption of blood-brain barrier, but vessel wall is preserved. There are different types of multiple sclerosis, and the first one and more common one is the relapsing remitting multiple sclerosis, in which symptoms flare up followed by recovery, and the patient stable between attacks. The secondary progressive multiple sclerosis is as the second phase of relapsing remitting MS. So it's a progressive worsening of the symptoms with or without superimposed relapses. The third type of MS is the primary progressive multiple sclerosis, which is a gradual but steady accumulation of a neurological problem from the onset. The benign MS, a few attacks and little or no disability after 20 years. The other type is progressive relapsing multiple sclerosis, in which there is a progressive course from the onset and sometimes combined with the occasional acute symptom of flare up. The last type is malignant or fulminant MS, which is a rapidly progressive disease course. Before we talk about the clinical symptoms and signs of MS, let us know what is condition suggestive of multiple sclerosis. And these conditions is very important, make us to suspect MS. And this includes afferent pupillary defect and optic atrophy, Lermite symptom, internuclear ophthalmoplegia, rubral or Holmes tumor, trigeminal neuralgia, especially under the age of 50, recurrent facial nerve palsy, and urinary sphincter disturbance. The clinical presentation of MS often varies among patients. It is important to note that patients with MS have subjective complaints and objective signs, and the MS is characterized by episode of neurological dysfunction followed by a period of partial to complete remission of symptoms, and these symptoms appear over a few hours or days and can be gradually worsening over a period of a few weeks, depending on the course and subtype of disease. And as we said, the most common subtype of MS is relapsing remitting multiple sclerosis. So there is certain signs and symptoms are common in early stage of disease, like change in sensation as numbness, about 33%, in the arm, in the leg, or the face, and initial after other common initial symptom is optic neuritis about 20%, weakness 13%, internuclear ophthalmoplegia about 7%, unsteadiness 5%, and imbalance problem 3%. This slide shows you different clinical manifestations of multiple sclerosis, and because the sensory is the most common presenting features, so like numbness, paresthesia, dysesthesia, Lermite sign, as we say, it is a suggestive condition of multiple sclerosis. It is electrical-like sensation run down in the spine when the patient bends her or his head forward. MS hug tightness around the chest, trigeminal neuralgia, or proprioception deficit. Visual symptoms is also common as a presenting clinical manifestation for MS. Motor symptoms like spasticity, weakness, hyperreflexia, gait and balance disturbance also common presenting symptoms of multiple sclerosis. This slide shows you the percentage of different clinical features of multiple sclerosis, and as you see, the sensory disturbance is 34%, weakness 22, visual loss 13, ataxia 11, diplopia 8. So the main presenting features of multiple sclerosis is sensory or motor or visual or cerebellar. Other clinical features may be seen in patients with multiple sclerosis is the urinary incontinence, cognitive and emotional abnormality like depression and anxiety, emotional liability, fatigue also is a clinical feature of multiple sclerosis, and the sexual dysfunction. The differential diagnosis of multiple sclerosis are many because the clinical and imaging finding that may be seen in MS can be also mimicked by some other disease like acute disseminated encephalomyelitis, ADEM, shoulder disease, and Palos concentric sclerosis, and Marburg variant of MS, in addition to neuromyelitis optica. Other inflammatory non-demyelinating disease such as Behçet disease, SLE, Sjogren syndrome, sarcoidosis must be differentiated from MS. Infection like syphilis, progressive multifocal leukoencephalopathy, HIV, HTL also kept in mind in the diagnosis of multiple sclerosis. Metabolic causes like B12 deficiency, lysosomal and mitochondrial disorder, adrenoleukodystrophy, and genetic disease, all these may be kept in mind in the diagnosis of multiple sclerosis. CNS lymphoma also must be differentiated from multiple sclerosis. The diagnosis of MS can be challenging because there are no markers specific for MS diagnosis, and the diagnosis mainly depend on history and the neurological examination. So the diagnosis of definite multiple sclerosis remains primarily clinical and depend on appropriate history with exclude of other possible causes. This table shows you the McDonald criteria, which is a diagnostic criteria for multiple sclerosis. The McDonald criteria were first developed in 2001 and later revised in 2005, 2010, and lately in 2017. And this table shows you the lastly revised McDonald criteria in 2017. Before we discuss this criteria, you must know several things. The first thing is you must know definition of the attack. You must know what is dissemination in time and what is dissemination in space. The attack defined as a new neurological deficit lasting more than 24 hours that can be associated with an anatomical localization in the absence of fever or any infection. Dissemination in time mean evidence of damage in the central nervous system at different date, while dissemination in space mean evidence of damage in different parts of central nervous system. So, if there is two or more attack and there is two or more clinical lesions in the central nervous system, this is definite MS. If there is two or more attacks with one lesion of the central nervous system, you need dissemination in space demonstrated by MRI or CSF or wait for another attack. If there is one attack with two clinical lesions in CNS, you need dissemination in time demonstrated by MRI or second clinical attack. If there is one attack and one clinical lesion, you need dissemination in space and time, which is demonstrated by MRI or CSF finding and second attack. If there is no attack, there is only insidious neurological progression suggestive of MS. You need two out of three of the following: either positive brain MRI, which compatible with the multiple sclerosis, either positive spinal cord MRI, also compatible with the multiple sclerosis, or you need positive CSF finding. In this slide and the coming slide, I will explain the MRI changes in multiple sclerosis. As you know, MRI is the most sensitive method for showing lesion in multiple sclerosis. Over 95% of patients with a clinically definite multiple sclerosis show MRI changes which is compatible with the multiple sclerosis. This slide shows the characteristic MRI lesion which is compatible with the multiple sclerosis. And so the character of the lesion must be large, more than 3 millimeter, ovoid, oriented perpendicular to ventricle, enhancing either open ring enhancement or multifocal homogeneous. The location of the lesion must be multiple in white matter or brainstem infratentorial or juxtacortical, and also it may be in corpus callosum like pointing away, mouth eating, and callosal atrophy. You must need to keep these two statements in your mind that abnormal MRI without the clinical evidence is not sufficient to confirm the diagnosis of multiple sclerosis. Also, absence of abnormal MRI in clinically definite multiple sclerosis does not disprove the diagnosis. This slide shows you the typical lesion of multiple sclerosis by MRI. As you see, the multiple ovoid white matter lesion and periventricular location which is compatible with the MS. This is also the MRI lesion which is characteristic to multiple sclerosis. This picture shows the corpus callosum lesion of the multiple sclerosis. As you see, it is pointing away with callosal atrophy. The spinal cord lesion in patients with multiple sclerosis must be focal, and about 80 to 90% of patients with MS have focal spinal cord lesion, and it differs from a lesion of neuromyelitis optica, in which the lesion of neuromyelitis optica is extended over 3 or more segments, while in MS it is a focal lesion. And this image shows you the focal lesion of the cervical spinal cord, which is compatible with the diagnosis of multiple sclerosis. And this MRI image show you a spinal cord lesion which is compatible with the neuromyelitis optica. As you see, it is extensive, elongated, and extend more than 2 or 4 segments of the spinal cord. The CSF abnormality may be seen in 85 to 90% of patients with MS and is include mononuclear piliyocytosis less than 50 cells, increased intrathecal synthesized IgG and oligoclonal bond, and paired serum samples study to exclude non-CNS origin of any oligoclonal bond in the CSF. The evoked potential also may be abnormal in patients with multiple sclerosis, and about 75% of patients have visual evoked response abnormality. The brainstem auditory evoked response may be abnormal in 30% of patients, and also somatosensory evoked response abnormal in 80% of patients. The treatment of multiple sclerosis is divided into 3 parts. The first part is the treatment of acute relapse or attack. The second is the using of drug modifying therapy for the treatment of multiple sclerosis. And the third part of the treatment is symptomatic treatment of different neurological complications caused by multiple sclerosis. So, the treatment of acute relapse or attack, as you know, we define the attack as a new or worsening neurological deficit lasting 24 hours or more in the absence of fever or infection. So, there are similar symptoms or condition occur in the presence of fever, heat exposure, or infection. This is not relapse. This is commonly called pseudo-exacerbation, and no need for the treatment of pseudo-exacerbation. So the treatment of acute relapse is by methylprednisolone 500 mg to 1000 mg daily for 5 days and may be followed by tapering oral steroid. If there is no response or if the disease is fulminant type of MS, we use plasma exchange or IVIG for the treatment of acute relapse. This table shows different type of drug modifying therapy used for multiple sclerosis, and these are either injectable or oral form. The injectable form is interferon beta 1b beta seron subcutaneous, interferon beta 1a Avonex intramuscular, and glatiramer acetate or mitraxantron or interferon beta 1a Ribif subcutaneous or natalizumab injection, elmituzumab, and pegylated beta interferon beta 1a. The oral types is fingolimod, gilenia, teriflunomide, and dimethylfumarate. All these are used as a drug modifying therapy for patients with multiple sclerosis. You must monitor the patient with MS after starting the interferon beta therapy, and liver function test and CBC at the baseline. Lab tests then should be repeated at 1 month, 3 months, 6 months during the initiation of therapy. Monitoring can be then performed every 3 to 6 months. Thyroid function tests are recommended in patients with history of thyroid disease every 6 months. This slide shows you the adverse effects of beta interferon, and the common one is the inflammation at the site of injection, headache, flu-like symptoms like myalgia, fever, rigor, rhinitis, and fatigue, and the rare side effect are depression, suicide, epileptic event, thyroid abnormality, lymphopenia, thrombocytopenia, asymptomatic elevated liver transaminase level, and rarely symptomatic hepatitis. So, when starts beta interferon, the patient must monitoring as we discussed it in the previous slide. As we said in the treatment of multiple sclerosis, the third type of treatment is to treat the neurological complication that caused by multiple sclerosis. So the spasticity is treated by baclofen or tizanidine or benzodiazepine, dantrolene, and botulinum toxin type A. This slide shows you the symptomatic treatment of multiple different neurological complications caused by multiple sclerosis like tremor, fatigue, bladder dysfunction, depression, sexual dysfunction, cognitive impairment, anxiety, ataxia, trigeminal neuralgia, and tonic spasm. There are many factors that influence the prognosis of patients with multiple sclerosis, and the favorable factors is females, gender, low rate of relapses per year, complete recovery from the first attack, long interval between first and second attack, symptom predominantly from sensory symptoms, younger age of onset, low disability at 2 to 5 years from the disease onset, later cerebellar involvement is a good prognosis sign, involvement of only one CNS system at the time of the onset. All these are favorable factors that lead to good prognosis in patients with multiple sclerosis. Clinically isolated syndrome is an episode of symptom of demyelinating affecting the optic nerve, spinal cord, brainstem in isolation. 85% of MS patient onset is heralded by single episode. Guidelines give beta interferon a level A recommendation for the use in the CIS. Early initiation of the treatment can delay the progression to clinically definite multiple sclerosis. This slide shows you how to differentiate between neuromyelitis optica and multiple sclerosis. The distribution of symptoms and signs in NMO restricted to the optic nerve and spinal cord, while in MS, any white matter tract. The severity is usually severe in NMO while it is mild in multiple sclerosis. The MRI brain usually normal or non-specific changes in NMO, multiple periventricular white matter lesion in the MS. The MRI of the spinal cord NMO goes longitudinally extensive central necrotic lesion extended over more than 2 to 3 segments, as we said before, while in the multiple sclerosis it is focal small lesion. The CSF in the NMO peliocytosis during attack, it is rarely more than 25 to 50 white cell in multiple sclerosis. Oligoclonal bond in the CSF usually absent in the NMO and usually present with multiple sclerosis. Permanent disability is usually attack related in the NMO, while in the MS usually in late progressive phase. Female patient 80 to 90% in MO, 60 to 70% in multiple sclerosis. Coexisting autoimmune immunity is frequent with neuromyelitis optica, less common with MS. Serum neuromyelitis optica antibody are present in neuromyelitis optica while absent in the multiple sclerosis. Now we discuss the optic neuritis and the clinical feature and how to treat the optic neuritis. The optic neuritis, as you know, it is an inflammatory demyelinating lesion of the optic nerve. Usually it is in young female. Pain associated with pain, periocular pain, worse with extraocular muscle movement. The visual acuity can be normal. relative apparent pupillary defect during examination, visual field defect, and the fundus as 60% to 70% of patients have normal because of retropulbar neuritis. The clinical features of optic neuritis is usually subacute monocular visual impairment associated with pain in or around the eye is present over 90% and typically exacerbated by ocular movement, may be preceded or accompany the visual loss and usually last a few days. And the usual age for the optic neuritis is 20 to 50 years, mean around 30. The frontal headache and tenderness of the globe may also be present. Treatment of optic neuritis is similar to the treatment of acute relapse in patients with MS and is treated by intravenous methylprednisolone 500 mg to 1000 mg per day for 3 to 5 days, followed by oral prednisolone. And the treatment must be as early as possible to, to prevent the complication of the optic neuritis, which may lead to the blindness. The differential diagnosis of optic neuritis is either papillitis, like papilledema ischemic optic neuropathy, pseudopapilledema anterior orbital compression neuropathy, or acute retropulbar neuritis, like hysterical blindness, malingerer, indirect optic neuropathy. Now we talk a few points about ADEM, acute disseminated encephalomyelitis. It's also known as post-infectious encephalomyelitis or post-vaccination encephalomyelitis. It is a demyelinating disease of the central nervous system that typically presents as a monophasic disorder, not like MS. The MS is multiphasic disorder, while the ADEM is a monophasic disorder and is associated with multifocal neurological symptom and disability. Also, ADEM is associated with encephalopathic process, not like multiple sclerosis. Encephalopathy is not a features of multiple sclerosis, while in ADEM, the encephalopathy is a features of acute disseminating encephalomyelitis. The treatment of patients with ADEM is by methylprednisolone IV for 5 days, 500 mg to 1000 mg per day for 5 days. If there is good response, after that, short course of oral prednisone. If there is no response, consider plasma exchange or IVIG therapy plus supportive care. Thank you for your listening.